Dr. Wilson, going to turn it over to you. Take it away.
Okay, great. Hi, everyone. Nice to see you again. We had a great turnout today and a great turnout 2 weeks ago on our IPR course. So anyways, I'm super excited that some of you are back. For those of you who are new, I'm going to go ahead and kind of take you a little bit through who I am and what we're going to be doing today. So this is kind of one of my favorite courses that I do. Here we go. This is me. Hi. I'm Amanda. I'm an orthodontist. Been practicing almost 20 years. I worked private practice in the San Francisco Bay Area for 10 years, and then I kind of made a pretty sharp pivot. I ended up getting into consulting, helping doctors produce more orthodontics, more ideal orthodontics, and product creation. So that's what I'm doing right now. If anything I talk about today is something that you'd like to know more about, I have a lot of free resources I can send you. So that is my website and that is my email. Feel free to reach out to me. I'm super, super happy to talk to everyone and anyone, no matter what it's about. And I know that Kevin said that he did park a copy of, or he can send you a copy of the webinar from 2 weeks ago. I also parked it on my webinar website where I kind of archive all my webinars, but you can go there too. But either way, you'll get a copy. That's the main thing. All right, so today we're going to be talking specifically about ortho, all about ortho. It's just going to be like a super high level lecture about orthodontics. This is mostly designed, I would say, for general and pediatric dentists in terms of, the level of complexity that I'm going to talk at. If there are orthodontists on here, that's wonderful. You probably know all of this already. So maybe grab a glass of wine if you just want to review. I also want to talk about, I guess, my personal objectives for this lecture, and it really is just something I love to just educate doctors about. My goal here is not to take, cases from the orthodontist, not at all. I really do support my profession, but realistically, orthodontics as a profession has changed in the last, generation, and we all know it, and we have to change with it. So a lot of times patients, they, as a general dentist or as a pediatric dentist, you can do any type of dentistry you want as long as you can do it to the level of a specialist, right? So that's what we learn in dental school. So if you want to pull teeth, that's fine. If you want to work on little kids and do little kids stainless steel crowns, that's fine. You get the idea. Same thing with ortho. I think for a really long time, for the most part, general dentists stayed away from ortho because it was too complicated, right? It was just something so different from what they were doing. But in the last 20 years, and we're going to talk about the evolution of ortho and how technology has made it easier. It's a double-edged sword for those of us in the profession. On one hand, it's wonderful because it's just so fun right now. It's just way more fun than it even was. And I think it's become more accessible to the average, I'm going to say average American, I'm going to reference Americans, but average consumer anywhere in the world. It was used to be something that only the wealthy could get, and now it's not anymore. Everyone can get ortho of some sort, somehow, some way. So, that's the why behind it. In addition, even let's say you don't even want to do any ortho in your practice. You have no interest in doing any ortho, and that's totally fine. But I still think you should listen to this lecture because you still, as a dentist, you need to refer your patients out when they need something, right? When they need to see a specialist. And I think the biggest mistake that a lot of general dentists do is they don't qualify the referral. And what I mean by that is this drives me nuts when they just hand a brochure and say, oh, you're 7 now. You need to go see an orthodontist because that's what you do at age 7. Well, that's a terrible answer because as a parent, especially now post-COVID where you're just hesitating to go anywhere you don't need to go, especially a doctor's office, I'm going to say, well, why? I mean, can't she wait till she's 12? You as a doctor should know the answer to that. Even if you're not even going to touch the ortho, you need to be able to answer the why. Why are we referring? What is going to happen if we don't treat the patient now? Is it going to get worse? Is it going to get better? So these are things we're going to talk about a little bit today. And if you're interested in digging into any more of these or any of the appliances I'm going to talk about, like I said, this is going to be a super high level view. I am super glad to talk to each and every one of you. Just shoot me an email and we'll set up a time to talk. It's free. I'm glad to help you. Education is part of what I do. So anyways, again, orthos out there, we're not here to take patients from you. As a matter of fact, the doctors I work with generally send way more patients than they ever did to ortho because they understand it. They know where the line is, where they should not be stepping and where they should be stepping. And that line is going to be different for every dentist. in terms of what services they offer or what type of orthodontics they offer is going to vary with every dentist. Some dentists are going to be a little more adventurous, some aren't. If you're in a very small town or a very urban area where maybe accessibility to an orthodontist isn't, ideal, then this is something you need to know, because sometimes you're going to have to treat your patients because it's just not going to be possible for them to get care elsewhere. So like I said, that line is going to be different for every dentist. So some might do a lot of different types of procedures. Some may only stick with like a type of aligners, and that is fine. It's whatever works for you. And if you're not sure where that line is, I'm glad to talk to you about it. So again, today's going to be high level. We're going to be talking lightly, and not in this order, but about phase 1, functional appliances, airway appliances, straight wire, indirect bonding, aligners, both branded and unbranded, hybrid, if you don't know what that is, and the whole retention orthodontic aftercare opportunity. Wow, that's a lot of information. So I'm going to talk pretty fast because that's my style. I'm going to ramp it up so you can get as much information as possible. Don't forget, if you want the CE credit, you need to stay until the end because there's going to be a couple quiz questions, and they will all be in this lecture, and they should be really easy, hopefully. But let's talk about the why. So we already talked about the why. We said, number 1, your patients are going to be asking for it. You can do it if you want to do it. The stuff that maybe you don't want to do, you need to punt, and you need to qualify the referral. But ultimately, the vast majority of doctors I talk to want to do ortho. They want to learn ortho because they want to do more of what they want to do. So they're realizing, in order for me to do these veneers, in order for me to do this cosmetic work, in order for me to place this implant ideally, I need to do X first, upright the molar, flare the incisors out, get more overjet so my veneers don't get knocked off, whatever. But a lot of times when they try to communicate that or send the patient to the specialist, it ends up being like really expensive. And or the patient's like, ugh, I don't want to go to the specialist. Can't you do it? So sometimes it's a way for you to almost bundle that package. I like to talk about bundling the ortho plus the cosmetic work into one big price tag, right? But so they're fully committed to the whole bundle. And you can, that way there's no back and forth. Like, can you just torque those incisors out a little bit more? I need a 10 degrees more uprighting. If you're doing it yourself, it's so much easier. So that's the why behind it. So it's really a win-win, not only for patients, but also for doctors and orthodontists. So now we've addressed the exciting why behind it. Now let's talk about pain points. These are the top 3 pain points that I get when I talk to doctors, and I love to talk to doctors, as I said. But the first one is cost, right? They're like, oh, this is gonna be so expensive. I gotta fly somewhere, I gotta take a class. That's not true at all. Almost all, at least the aligner companies now, and a lot of other companies that are out there, including some stuff that I offer, is all digital. So gone are, I think, the in-person classes. It's pretty much not happening anymore. Nobody wants to fly anywhere for stuff. And you can, just like Garrison's thinking about doing with some of their hands-on courses, very similar to what you can do to learn ortho. There's a lot of stuff out there. So don't worry about the cost. And a lot of stuff is free. You can get started with a lot of different systems for free. It shouldn't cost anything to take the class, especially if you understand it. In terms of equipment, you don't have to have anything, but I would strongly recommend investing in an intraoral scanner. If you haven't already, you can get a really, really good one for about $18,000 with the monitor and everything, really portable. No additional like crazy monthly fees with the training. If you need a referral, I'm glad to send you. But it's $18,000 and up, but that should be enough for ortho. And you can use it on all your restorative too. Think about just the patient experience is going to be so much better. And I'm going to be talking about so many other different opportunities, and you might get so excited about, $18,000 financed over 5 years is really, it's a pretty low cost. It's like a Toyota payment. So I'm pretty sure for the amount of ROI it's going to bring back, it's something that you can definitely do. What else? Number 2, we talked a little bit about upsetting the status quo referral pattern. And I really support orthodontists in the community. We shouldn't be upsetting that at all. You'll still be referring. Matter of fact, you're going to be referring even more than you ever did because you're going to be seeing so much more, right? So it may be a conversation if you want to get started that you're going to want to have with your orthodontist, if that's your buddy. If it's not your buddy, oh well. If it's not your buddy, my suggestion is, look at the opportunity. What are they not doing? Because you're going to get your patients coming back finding, oh, they want to pull four buys on every tooth. That might not be something that there's an opportunity for you, you know. They want to put headgear on every patient or something like that, or they don't believe in early treatment. They don't believe in airway. Those are the most common things that I get where it's just maybe your orthodontist was trained a little while ago, and I can tell you in the last 20 years, orthodontics has, the whole vision has totally changed. How we practice has totally changed. So some orthodontists maybe haven't evolved as much, and that's fine, that works for them, but it's an opportunity for you. So number 3 would be inefficiency in margins. So I would say most doctors I talk to have tried a case, 2 case, 3 cases, but they end up not liking it. But that's just because you haven't found the most efficient way and the most productive way to do it. And you haven't trained up your team so that they can run the program. So there's a lot of different ways. And we're gonna talk about all different types of, the thing about me is I'm not directly affiliated with any real brands or anything like that. So I pretty much work with everything. When doctors come to me, I'm like, cool, you wanna do Invisalign, that's great. You wanna do white label aligners, that's great. You wanna do 6-month smiles, that's great. You know, it doesn't matter, but there's always generic versions of everything that work just as well, sometimes better, but you just might not know about them, you know, and they're unbranded for a reason. It's kind of word of mouth, but it's totally legal. You can do it. It's not going to be shiny and fancy, but it's going to work just as well, if not better sometimes, and you're going to save a heck of a lot of money. So we can talk about that too, because I think if you had better outcomes and you were more efficient and you had lower lab fees, you might be more excited about doing ortho. All right, so I like to talk about ortho being in 3 buckets, okay? So buckets meaning I really strongly recommend that you offer all 3 buckets in your practice, and I'll explain the why behind that. First of all, opportunity. Second of all, you know, it's better for the patients, but they all kind of go hand in hand. And sometimes you start one, if you start phase 1 patients, well, they're all probably gonna turn into some easy aligner patients later. So, and you might be starting aligner patients that are only adults, and that's how most doctors start, but then they all have kids, and then they want you to see their kids, right? So ultimately, as the word starts to get out, you know, you're gonna have to offer all 3 at some point. Otherwise, it's gonna be hard to separate a family. Like, I can't see you because you're phase 1, so you gotta go to the ortho, or you want braces, so you gotta go to the ortho, but I only do aligners. Just do it all. It's way easier. Plus, sometimes people change their mind and you have to change gears. So it's nice when you have different things to offer. Okay, we're gonna be talking about, first of all, I wanna get one thing out of the way, and that is the definition of comprehensive versus STO. So short-term orthodontics is kind of what I would call 6-month smiles, fast braces, clear correct flex for the most part, and of course, Smile Direct Club is, I would call STO. That is something where you're not, it's more like limited. So if you're doing STO, you probably need to be billing your D80/40 or below, 30, 10, 20, because that means you're doing limited orthodontics for the most part. All you're doing is treating one thing or one component. You're not necessarily fixing everything. You're not uprighting the roots. You're just making it cosmetically better. Maybe you're just doing the social 6. Nothing wrong with that at all. That's totally fine if that's what your patient wants. And that's like one of the big things, like I said, that's changed in ortho in the past generation is there was none of that 20 years ago. You know, it was like patient came in, this is what you need, this is how I'm gonna do it. And patients really didn't question for the most part. But now that they see all these ads on their phone, you know, like, hey, you can get started with upper aligners for $17.95, you know, close your gap only. They realize that they can have a little bit of control, and that's totally fine. You know, obviously you need to be able to sleep well at night with your treatment plan. So I like to tell patients, yeah, I mean, as long as the risks outweigh the benefits and you're educated on the risks, benefits, and alternatives, we can do STO. That's totally fine. But here's my concerns, and we talk about what won't be perfect and what will be perfect, and then you really need to write that down and have the patient sign that. I call that compromised, or something, you know, something where they realize they're not getting perfect, and they're maybe getting a price, you know, discount with that. But as long as you do that, that's totally fine. There's nothing wrong with that. So again, we kind of talked about that. Comprehensive is fixing the bite, finishing the cases ideally, including torque and root uprighting. Whereas short-term ortho is going to be anterior alignment, finishing cases in round wires, and you'll have a lot of necessity for permanent retention if you do that. Let's talk a little bit about what type of records you need in order to get started with ortho. So there's 3 main ones that I would say would be standard on any type of ortho potential patient. So obviously orthodontic photos, I call that the 8 series. So you can see that you're gonna have 5 intraorals with retractors. Ideally, you're actually getting it so, I'll take Let's see if you can see my mouse. We want to be able to see at least the buccal occlusion on the molar, at least, that mesial buccal cusp, how the angles occlusion is. So this is a really great photo here, an example of how to take photos. If you're not, and this needs to come in at a right angle. If you're not taking ideal photos, there are some classes and stuff I can send you to. I have some resources. I'm glad to send you this. But it really just comes down to practice. So I would definitely take your team and you need to get a camera that's designated just for photos for the office. It can't really be like a cell phone unless it's an office cell phone, because it can't be something that's connected to, could possibly where you can access HIPAA compliant information. So that's something that you might want to think about. But nowadays you can get like an iPad, just an office only iPad for pretty cheap, and it stays in the office, and then each of the teams is required to download their photos at the end of the day, and get them back in the chart. So it does take like a few minutes per patient, but it's a really great idea to be able to have digital photos. What else do you need? You need to have, X-ray. You guys all know what an X-ray is. So pano X-ray, right? And the why behind this is a lot of times general dentists will only take FMX, but you really sometimes get surprised, as you can see with this case right here. Story behind this case is that the patient had only had FMX, so they standard, 2 PAs and then the bite wings. And they kind of thought that those canines the baby canines were permanent canines. I don't know why, because they look different to me. But, they didn't realize that they were up in the sinus, right? So that's why you have to take it. A lot of times you find pathology too. Of course, wisdom teeth, it's helpful. So every 5 years, I do recommend, and starting ortho, I do recommend getting a pano. Most orthodontists do not charge the patient for the pano, for the screening, just because it's ortho screening. That's going to be however you choose to do that. The more you charge a patient for records, the less likely they're going to want to move forward. So ortho consults should be really done on every patient, age 3 and 4 and up that comes into your practice. Every single patient is a potential opportunity, whether it's for you or for the orthodontist down the street. But even starting to screen at 3 and 4, I do recommend, you don't have to say, hey, do you mind if I do an orthodontic consult? Because that's really standard of care. I think it's you just literally taking photos. Photos should be taken on every single patient in your office, photos or a colored scan. I like photos better, but a colored scan works too. But just having that documentation every, year, every 12 months or so, and having the sequential series of photos is incredibly powerful for selling any type of case, whether it's restorative, it's ortho, whatever it is, implant, here's some of the different things that you can be referencing in a photo, in terms of, and also increases increases treatment acceptance, and it helps to mitigate risk management. Because if you have photos, the proof is in the photos if you have good ones, right? You can't have junky photos, so you have to really work on quality photos. But over time, if you start doing this, even if you just lightly talking about it, hey, Mrs. So-and-so, I know we took photos last year, we took photos this year, last year we kind of talked about how, goodness, you're having some attrition and some abfractions and you're having some inflammation around tooth number 26. And today, we took another set of photos, and let's pull up the old photos and the new photos, and you pull them up. And then you say, hey, look, I see some things are getting worse, and you refer to them. And, ultimately, we want you to keep your teeth for the rest of your life. It's much cheaper to keep your teeth than to have to get, all in fours or whatever. But if we keep, some of these are progressive conditions. So once they get started, they're not going to get better unless we change your bite. So that's why we really wanted to talk to you about ortho. And a lot of times people think, especially in their 40s, 50s, 60s, they think they're too old for it, and they just think it's only for kids. So it's a great idea to just bring that up with the patient and start taking photos. Here's some additional records that might occasionally be helpful, but this is more if you're taking harder cases. So one would be a Ceph. I am of the opinion, this is just my personal opinion, that Cephs are pretty much standard of care in an orthodontic office when you are changing the bite. So if you are growing a jaw, drastically changing the AP, which is, like overjet, stuff like that, yeah, then you should take a Ceph. So if you're going to be starting to do that kind of bigger stuff, growth modification, you should consider finding a way to take the Ceph. Now, that tends to freak out doctors a lot because they're like, oh no, it costs a lot of money. But sometimes, like it's not going to be every patient. That class 1, ortho relapse case that just needs 10 aligners doesn't need a SEF. I mean, that's risk, benefits, and alternatives here, right? It's not necessary. So you're just exposing to the patient something that's not, you're not even going to look at it. So you can often find an oral surgeon nearby that you refer to. If they have a CBCT, most likely, and they do oral surgeries in terms of like jaw surgeries, they definitely can take a SEF for you. And maybe you can work out some type of process where you compensate them. The only thing I wouldn't do is I wouldn't have the patient pay additionally, especially if you're still in the screening process, because that's going to really limit, the amount of consults that you can do if you need that information. Beyond that, hand wrist x-rays are awesome, especially if you're a pediatric dentist. There's so much you can learn from. I have a really great guide. I wrote it myself on how to read it in an easy way, so you can kind of know the skeletal maturity of the patient. So glad to send it to you if you're interested. Just send me an email. Perio charting, of course, is useful. And of course, we talked about CBCTs. Really nice if you have it. I mean, especially if you're trying to make a decision about, should I flare those incisors out, should I pull them back? You're trying to make a decision and you want to look at the bone. It's really great. And of course, for impacted teeth, it's great too, but it's not necessary on all patients. Okay, let's start moving into different types of treatment. So different types of products that are out there. Again, we're going to talk high level. We're not, this is Garrison. So Garrison is actually it's a dental supply company, mostly focusing on, IPR. They're focusing on matrices, different types of burrs, finishing and polishing discs. So they're just super nice that they're bringing this, because they just want to educate you guys, because they know that a lot of their doctors, also want to do ortho. So super honored to be here. But again, we're not sponsored by any aligner company, so I'm going to talk about stuff really high level. Keep in mind, there's like, I don't know, 50 to 100 different aligner companies in the world. So there's a lot of them out there. Most of them work great. It's just a matter of what works for you. So let's talk a little bit about the orthodontic patient referral and how this has changed in the last decade. And I think most of you are kind of aware of this, that like we talked about, pre-1997, I mean, pretty much everything went to the orthodontist and pretty much everything was braces, right? That's all we pretty much had. Align Technology was founded 97, 98, really came out in the market by 2001. That's, when I was going to ortho residency. So I know at the time, it's kind of funny, our head resident and head program advisor told us if we took the Invisalign course to get certified, even on our own time, even on the weekends, in any way, shape, or form, he would kick us out of the program. So, I mean, he said it's BS, it doesn't work. And back in 2001, it was pretty bad. So it really didn't work that well. So, but of course, since then, it's actually become a very good product. So they've really improved. 2006, I think, ClearCorrect came out. So that's about the time when the general dentist really started getting more into aligners, the easy relapse cases, stuff like that. And then since then, there's been so many different types of new aligners that have come out. Invisalign's first round of patents expired, I believe, about 2 or 3 years ago, which really opened up the market to like everybody doing aligners. So the prices have gone way down, maybe not the Invisalign prices or the ClearCorrect prices, but the overhead prices have gone down for people to start their own companies or to even do it in-house. So a lot of people are jumping on that bandwagon, and it's pretty fun. Okay, so since we mentioned, again, this program is not sponsored by any aligner company, so I'm just going to talk about this real high level. But the two main guys out there are, of course, Invisalign and ClearCorrect, right? Invisalign still requires you to become certified. They're always changing their training options. Last I looked, it was $29.95 for the destination, and I think it was around $1,000 for the digital, but sometimes it says it's $3,000 for the digital. So I don't know. Every day it's different, so don't call me on that. Whereas ClearCorrect, you do not have to take a course in order to get started, but they do have destination and digital courses. I would strongly recommend that you take some type of course or educate yourself in some way. There's lots of different ways out there before you get started with any aligners, because otherwise you're going to be winging it, and you might get some pretty bad outcomes. Lab fees, of course, are about 20–30% less for ClearCorrect as for Invisalign, but ClearCorrect comes with retainers. Invisalign is really only compatible with a handful of scanners, for the most part, only iTero. So you have to send impressions, and they're very picky about their impressions, which I think is a good thing. But if you have a Medit or a 3Shape or something, you can't send it to Invisalign. And there's a few workarounds, but for the most part, they're pretty clunky. So it's kind of a bummer. So, I mean, I think it's kind of a mistake personally on their part, because a lot of doctors are leaving, you know, just because it's like, hey, I have a scanner, you know, it should work, but, you know, that's just political, I guess. Whereas ClearCorrect pretty much takes any open scanner, which is nice. So since we're talking about aligners, let's talk about just kind of the nitty gritty of how to have your aligners be successful. And a successful aligner requires a partnership from all different directions, right? So if you're using Invisalign or ClearCorrect or one of these ones that is everything in one, it's kind of turnkey. A lot of the responsibility is on them, but still a lot of it is on you. And the biggest mistake that most general dentists that I work with is that they don't realize their own responsibility. So of course, case selection is your responsibility, right? Always good to pick easy cases, class 1, mild to moderate crowding, ideally no perio, simple relapse cases, simple cases. So, but a lot of times doctors get over their head and take cases they probably shouldn't be taking, you know? And you got to realize that the design team for these two companies are offshore. They're not all dentists or orthodontists. Matter of fact, most aren't. They might have a few at the very top, but the likelihood of them seeing your treatment plan is 0 if you're just getting started, most likely. Sometimes you can call on one, you get a few credits to talk to one or whatever, but you know, they're not US licensed, so you know, you can use much better to talk to a US orthodontist if you're gonna do that. That's just my suggestion, because some of the stuff I've seen them tell doctors to do is not so good. So again, that's case selection, that's also the design and treatment plan. You need to know what you're doing. Just because the computer says you can do X doesn't mean it's even possible. And the sheer amount of treatment plans I see that aren't possible that come to doctors is just, it's sad. It really, really is. It's either not possible or maybe it's not healthy. I mean, these companies like Invisalign or ClearCorrect, they don't know if you're gonna throw the roots through the buccal plate if you flare them forward. They don't know. They don't have a CBCT. They haven't felt the patient clinically. They have no idea. And I don't think, you know, that's really it's your responsibility to know that. So if they make a treatment plan that flares them forward, you have to say, well, should I be doing that or should I not? You know, how you have to give them direction. So do this, put them this. They're literally just taking a stab in the dark. And if you don't give the right direction as to how the treatment plan goes, you might not get a good treatment plan. So, and of course, the other component that for the most part, general dentists kind of lack is the whole compliance piece. Compliance is key. Compliance. Every patient can be a compliant patient, but you need to partner with the right ones. And learning just to screen these patients, also just explaining to the patient their role, their responsibilities, coming up with that paperwork so they realize, you know, what's going to happen if they continuously miss appointments or continuously lose their aligners, or they're not wearing them as directed 22 hours a day. Over time, you're going to learn, you know, to be able to point that out like a mile away and like, oh, they're just not being compliant, right? And you'll probably have the paperwork to support it and what to do next. But initially, that's probably, you're going to have some really great patients who totally do what you say, but you're going to have more that don't. So you're going to have to come up with a compliance check-in program. I really strongly recommend that you use one of these turnkey programs. There's a bunch of them out there, but you need to be checking your patients at least every aligner or two. And most patients don't want to come into the office. So Invisalign has a really great virtual tracking app now. There's also third-party tracking apps like dental monitoring or GP Ortho tracking. Lots of different options out there, but I strongly recommend that you look into that. I'm glad to send you a list of that if you've got questions. All right, so we've talked about branded aligners. Now we're gonna move on to white label aligners. So white label aligners may be something you've never heard of, and that's kind of just the generic term that the industry calls for aligners without a name, without a brand. So you might be doing the whole thing in-house, and there's ways to do it. I wouldn't recommend starting with that at the beginning. There's a lot of variables, and the chance of thing going wrong is high. So personally, I would outsource your white label initially. So the price point on that is $90 on the low end for a setup, and it's like kind of like a ClinCheck. I mean, obviously ClinCheck is a proprietary, you know, type of plan that comes through the Invisalign portal, right? But just like we call Kleenex, you know, tissues Kleenex, we call, you know, ClinChecks the setup. So the setup is done by a third-party company. There's 4 I usually work with. On the low end, it's about $90. If you're doing volume, it's going to be less. So they're going to take your STL file, they're gonna do a little setup, they're gonna take your prescription and your feedback, and they're gonna make the little digital setups to show what it looks like, AKA the ClinCheck. You're gonna say yes, no, or change it. And then when you're happy, you're gonna hit approve. So it works the very same way. And then once you approve it, that setup, that digital setup is gonna be sent to a third-party lab. There's a good couple dozen of third-party labs, just regular labs, like that you might use for crown and bridge, that can now manufacture aligners. Now, I'm going to give you a warning here. Careful. I would always use one of these aligner design companies to do the setups, because if your lab isn't using one of these, the chance that they know what they're doing is low. So, because these ones really use orthodontics from other countries, they really have a small volume and they take the time to make sure there's a good setup. So there are some labs out there that I know that are winging it, just using, a software, and they really don't know anything about ortho. So just careful. And if you have a question, feel free to ask me, and I kind of know who's doing what and the quality that's there. So anyways, yeah, so you send it to a manufacturing facility. Price point starts at, I'd say, about $15 US per aligner. Not all labs are alike. Not all manufacturing companies are alike. I have a few that I like. Right, oh good, I've got demos here. So since we're talking about that, okay. So for example, I can't even see me. Oh, here I am. Okay, great. So for example, this is Invisalign, right? So can you see it? Invisalign's trim right there. So you guys are pretty familiar with that, right? Okay. This is Clear Correct. You can see that. That's their trim. So it's a much higher level trim line. Nothing wrong with that. Personal preference. Obviously, if you have a higher trim line like this, then you don't need as many attachments. This is a much more rigid plastic. You can see I can barely bend it. Can be a little more uncomfortable for patients. A lot of times the trim can be uncomfortable. Whereas Invisalign's is much more scalloped. You can see that like that, right? This is a much more flexible. It actually stains a lot more too. But it has a higher modulus of elasticity, so it actually has slower and lower forces. So if I had to pick, I pick this one. And this is just a white, ooh, did I mess that up? I'm so sorry. This is Invisalign. So yeah, I get them all confused when I first look at it. Should have seen the branded. This one that I initially showed you, the really scalloped one. This is actually white label. So it's kind of a hybrid in between scalloped and the other one. It's a little more rigid, right? So this is Invisalign. See that? That's kind of crazy. So yeah, but I mean, the white label is really, really nice. So like I said, it's not going to come with all the fancy bling, but if you're paying only $15 per aligner, that's crazy cheap. Think about that. If you do the math, even with a $90 setup, that's $390 lab fee for a 10 upper and lower case. I mean, you can't beat that. Also, the cool thing about white label is that you don't have to pay the whole lab fee up front. So, obviously with Invisalign, you're paying what in the US, $1,863, $1,873 right off the bat. That doesn't even include retainers, right? So you're basically in the red, when you start a case. And that's really, we talked about inefficiency and margins. It's something that doctors hate because they hate, like, I don't want to start the case because I'm actually going to owe money until the insurance money comes in, until the patient pays more. That stinks. So I think Invisalign's failure to recognize this, well, they know about it, but is really a gain for the white label companies, because what a lot of them will let you do is you can just say, hey, let's say it's a 15 upper and lower case. Just print for me the first 5. I just want the first 5. In that case, they're only going to charge you, 15 times 5, well, times 10. I mean, that's not that much, right? So that's $150. That's your lab fee right now, because you're only paying for a third plus the setup. So that's great, right? It helps with the cash flow. You might have to pay extra on shipping. That's something you'll have to work out with them. But I know a lot of doctors that are doing that, and it just helps tremendously with cash flow. Of course, the other option is to do like a Care Credit or a Verity or one of these other ones to get your money up front, third-party financing. But a lot of patients don't like that. So, and the other cool thing, if the patients are paying monthly, and maybe if you do something like this with the white label, you can really lower your prices or lower at least your down payment so that the patients can get started. Because I think the biggest mistake doctors make is with Invisalign and some of these other ones, they require, a big hefty down payment in order to cover the lab fee. Well, the average American doesn't have $1,500 to put down. They just don't. And if you're only offering that, then they might go with braces someplace else. Or if you're only offering that, they might go with Smile Direct Club. So if you don't change the way that you're billing your aligner patients, and I think white label has its place in that situation, you're going to be losing patients to Candid and all those other ones that are out there, right? Because they have low to no down payments, and there's no reason you can't do that too, as long as you're, changing the ways that you're billing and maybe changing your labs. We talked about case selection, super duper important. You'd be surprised, you have to learn, this will come with time, what cases are appropriate for aligners and what aren't. Okay, let's move on. So aligner tracking, again, compliance, super important. I love using like dental monitoring or the virtual tracking app with Invisalign or GP Ortho tracking, and keeping an eye on those patients every single aligner. So they really come up with this go, no go method. It's a completely different way, right? Because when we first started doing Invisalign, they'd say, oh, just give the patient 4 aligners, come back in 4 to 5 aligners. Well, by then they might be crazy off and they don't even know that they're off. And once they're like this off, like in this picture, you can see here, there's no going back. You have to go do a revision, refinement, mid-course correction, which is going to cost you time and money. It's going to make the patient frustrated. You really should know what your revision refinement rate is in your practice. If your rate is more than 10, 20, 30, 40%, you're not doing things efficiently. And we talked about that, but really the aligner tracking virtual component is such an easy integration. It's super cheap. It's super easy. Obviously, you're gonna probably want to task a team member with managing that, but it's pretty easy to train team members to look to see if aligners are tracking, and patients can check in from home, and then you're going to give them the go, no go to go ahead and proceed with the next aligner. If you do that, and assuming you have a really good treatment plan, you picked a good case, your cases should sail from beginning to end without issues. You should be done, And realistically, a lot of the doctors that I work with are only doing their aligner patients in 3 appointments. So first appointment being the scan, the consult. Second appointment being the delivery, IPR, and which we talked about last week, and attachments. And last appointment being debond. So 3 in-office appointments. That is pretty awesome, right? Again, aligner tracking, super duper duper important. All right, moving on. So we're getting out of the whole aligner thing, and we're gonna move into the next bucket, which is phase 1 and functional appliances. So if you're a pediatric dentist, you're probably super jazzed about this. If you're a general dentist, you may not be that jazzed. But kiddos are kiddos, and I'm gonna get you so excited about seeing kiddos because they're actually the most fun patients possible. And doing phase 1 in functional appliances is a blast. It's so, so, so fun. And you know what? If you don't like kids, fine, who cares? Get a team member who does, because I guarantee you some team member in your office is one of those bubbly, fun people. Maybe they have kids, they love working with kids, and they would just own this. And you could give them little bonuses for, here and there, whatever you need to do to get them super excited. But the vast majority of phase 1 in functionals, you as a dentist barely need to touch the patient. It can be totally run by your team member. Of course, within your own Dental Practice Act, you're doing the diagnosis, you're doing the delivery, you're doing the treatment plan, but the check-ins can be done by your team members because there's really nothing that has to really be manipulated as long as you're using removables, which is my favorite. So this is actually my daughter. This is one of my favorite slides. But you can see here, we started in 3rd grade. We did some expansion. She had about 4 millimeters overjet, about 90% overbite. We expanded. We also have an impacted canine here. We consolidated the front spaces, and now we're actually in the fun part, which is the canine exposure. But at least we got the hard stuff out of the way. We fixed the bite. We got everything lined up in the phase 1 with removable appliances, and now we are moving on to the more difficult part. But this could be something where in your office you could do the fun, easy part, getting everything ready, the phase 1, and then you can punt it to ortho as needed for the phase 2 if there's something that you weren't expecting. It's only a small commitment, phase 1. So phase 1 is a small commitment, normally around 6 to 15 months, depends on when you're starting, where you're just fixing, it's interceptive, right? You're fixing initial problems so that everything, if you line it all up and you get the space, everything is gonna just come in hopefully peachy, at the end. Doesn't always happen that way. Weird things can happen. But for the most part, it does. And a lot of phase 1s, when you start them, sometimes you don't even need phase 2. So that's just a blessing. And if that happens, the parents are going to think you're the best thing ever. They're going to be singing your praises. Can't promise, never promise. All you can do is promise that It will help to make the phase 2 less complicated. You're taking the hard stuff, doing it now, early when the patient is compliant and likes to wear things. No one wants to work on 13 and 14-year-olds. It's not fun. They're grumpy. They don't want to be there. But the 8 and 9-year-olds want to be there, and they would love to wear whatever you give them. They think it's the coolest thing ever. It's just so cool. I can tell you when I was 8, I made retainers out of paper clips and now and layers, and I wore them to school, and I did such a good job making them that the teacher actually thought they were a retainer. And they told my mom, like, I think like in a conference, like, oh, she's wearing her retainer. And my mom's like, what? So who would have known I would be an orthodontist, but I did think they were super duper duper cool. So but yeah, phase 1 price point, I'd say people are charging between $2,500 and $39.99. It really depends on, you know, if you're in network, insurance, all that kind of stuff. Depends on what you're doing. Some people will start phase 1 even younger, and I call that kind of like a super phase 1 treatment, or you might do a pre-phase 1, which is maybe just like a habit intervention or an airway appliance. There's a lot of those that are really great for 3s, 4s, and 5s. If you're starting phase 1 though, you need to keep with the patient until you fix the bite. So I would say at least until the bite is corrected, and also the front teeth are out of harm's way. So that might mean consolidating, doing some braces on the top teeth, doing some express aligners on the top teeth, doing Invisalign first on the top teeth. So you need to stick with that patient. You can't just wear like a little rubber appliance and say, okay, I'm done with phase 1, because you didn't address all the patient's needs, right? And then in between phase 1 and phase 2, you're gonna have kind of a latency period, might be a few months, might be a few years, where you're just gonna keep an eye on them every 6 months until they're ready for phase 2. The great news is if you do phase 1, you can tell the parents that the likelihood of needing really complex stuff and invasive stuff in phase 2 goes down significantly. So it decreases the likelihood of needing jaw surgery, having impacted teeth, needing 4-by extractions or anything like that. And we really harness the growth of the patient in order to get a better outcome. So for example, if you take out upper buys on an overjet patient, all you're doing is just camouflaging, right? And you're making a suboptimal like patient profile. The profile isn't looking as good. Better to grow that lower jaw if you have a deficient mandible than to pull out upper teeth in phase 2, right? But the biggest mistake often that general dentists make is they don't realize that they need to harness the growth. So they have to really know where the patient is in their growth. And of course, orthodontists are really in tune with this. Pediatric dentists, pediatricians, we know when the growth spurt is happening. You're probably not gonna know, and you can't always tell by looking at a patient. You need to ask the right questions. And again, that's where it comes back to the hand wrist x-ray is really helpful, but ultimately you need to be asking those puberty questions. Can be a little bit sensitive. So you can always task, you know, one of your female team members to ask the questions on the girls if that's something that you need to do, but you need to know. Because again, we talked about understanding ortho so that you can qualify the referral if you're not going to be taking it. So if you don't understand, if you're not explaining to the parent that yes, we need to start phase 1, we need to send you to ortho because little Jenny here is 8 and you know, you're telling me she's already starting to go through puberty. Well, there's 8-year-olds that are done growing, like done. You go to a 3rd grade class and the teachers will tell you they're done. You know, they're fully grown 8-year-olds, especially girls. So girls are done growing earlier than 2 generations, you know, for sure, you know. Somewhere the average age I think is around 9, 10 now to be done growing. It's much younger. Boys as well, a little bit earlier, a little less so. So, you know, you have to time the growth with the maturity, and just they may only have 8 permanent teeth in, but yet they're done growing. So what do we do? You know, so that's why the phase 1, phase 2. That's why it's so important. So definitely want to talk about it. This is just a great example of one of my cases of how you can do phase 1 aligners. And I was doing phase 1 aligners before they were even like a thing. So Invisalign first obviously came out. It's pretty expensive. If you do Invisalign first, you also have to do Invisalign second. So that's like a $3,000 lab fee almost. Wow. But guess what? You can do it with white labels. You can do it with ClearCorrect. They're totally fine. They don't market it, but you can. You just pay for the flex price. Or in this case, I paid for the unlimited price because I figured that I have 5 years, right, to go ahead and do it. So I can do as many revisions as I want with unlimited, but really great for space consolidation, so much easier than doing braces on the front 4 teeth. Often you don't even need attachments if you take it slow and easy like I did here. No attachments, just wear it 22 hours a day. 9-year-olds, 10-year-olds, they would love to wear this. I think it's so cool, so definitely. So here's some of the different types of appliances, and I've got some of them here. I might show us for demos. So we've got, of course, dropping stuff. We've got expanders, right, with a little key. There's fixed ones and there's removable ones. Here's a nice little removable one. So this is called a Schwartz. So there's a little key that they're going to crank at home in order to widen the jaw. Obviously, this is a lower one. So on the upper, you're actually splitting the palate if the patient is still growing. If the patient's not growing, all you're doing is tipping teeth. On the lower, you're just tipping teeth, right? But it's a great way to develop out the arches so that if you, like I said, if you grow it, they will come. So if you develop the arches and put the arches where they should have been, you know, if they had developed ideally, then the teeth often just come in perfectly to begin with. So it happens. So that's the exciting part. So you've got myofunctional trainers, you've got space maintenance appliances, you've got different growth modification devices, like say a twin block that's here. What else? Habit appliances, headgear. Here's like a little fixed habit appliance. There's also removable ones. Don't have to do anything sharp or pokey. There's a lot of stuff out there. So many different things you can do. We talked a little bit about hand wrist x-rays. Again, I developed my own index for this to make it easy. If you have a ceph plate, you can take a hand wrist x-ray. Great way, especially if you don't want to ask the questions or if you have like a parent that's just not very communicative, you can just take the x-ray, get your answer. You know if they're going through puberty, if they're about to, how much growth you have left. I also have another handout called My Phase 1 Smile Index. Glad to send it to you. Normally there's a fee for that, or it's only for my clients, but anyone that was on this Garrison, as long as you contact me by the end of the week, I will send it to you. I usually want to talk to you first just to make sure you're going to use it in the right way, because I had some people that wanted to sell it once, so we might chit chat about it, but this is a great screening form just to make sure that you understand the why behind phase 1. You're checking all the different little boxes to know if this is a potential phase 1 patient. So, and this is just developed based on my experience with patients. It's also really important to have some type of sleep or breathing questionnaire. There's adult ones, there's kids ones, there's a bunch on the internet that you can get, that you can repurpose just with ideas, but you know, just questions about feeding, pacifier, oral habits, skeletal maturity, if they've ever had their tonsils out, if they breathe through their nose. I do recommend that you also take the time, especially if you're seeing like patients with open bites or narrow upper jaws, if you're seeing, you know, something that looks kind of off with the bite, to have the parents fill out a questionnaire like this. But more importantly, I would say have them come in, you know, at like 10, 11 o'clock at night, get their phone and tape the patient. You know, it doesn't even have to be. It'd be nice if it's a video, because it's nice to see them kind of their mouths open, stuff like that. But 5-10 minutes, a couple different blurbs, bring it into you, look at it, and you're going to see a lot of really interesting information about the patient's sleep, which is directly related to their orthodontic condition. So it's really quite intertwined. And parents often have no idea that, hey, you know, if I fix their bite, they're going to be sleeping better. Well, if they're going to be sleeping better, they're going to be acting better. They're going to be, I mean, I know you're extrapolating it way out, and I know it's really kind of fashionable right now. There's a lot of different courses about this, but it really is true. We can't make promises like, oh, we're going to cure this kid from this condition, but you can say that there is a correlation, and that often having a patent airway, a really good airway when the patient's sleeping, has a lot of favorable health considerations, and that's pretty much what you can say. You know, and that includes, of course, Malin-Potty, checking all that, checking adenoids, checking tonsils, and just having an idea about the airway. So talk a little bit more. We've talked about expanders, fixed, removable, bonded, so many different options out there. The cool thing about expanders is that you can bling them out, especially the ones with acrylic, the removable ones. The patient can customize them, put decals on them, really own it, and they just get so excited. I'm much more of a fan of removable expanders. I have no problem getting patients to be compliant. It's all in how you explain the why behind it. Usually you're going to have way more emergencies with a fix than you were with a removable, and I mean, they're not like huge emergencies, but it's annoying, you know, in terms of disruptive for a practice. So removables, I mean, it's fully on the patient to wear them. So, but for the vast majority, they wear them great as long as you explain, and you don't have to worry about all the food getting stuck up there and the infections and stuff like that can happen with fixed. We talked a little bit about growth modification devices, ways to grow lower jaws. There's tons of appliances out there. The other option is a way to distalize the upper teeth. I'm more of a forward person. I want to move teeth forward and not back. I want to increase the airway, not decrease it. So as much as possible, if the patient's still growing, I want to try to address the issue at its cause, which is growing a mandible or growing an upper jaw in a class 3 case. So one or the other. Again, talking about class 3, lots of cool little like removable bite jumpers you can do. Very, very easy, but also don't be afraid of the face mask. The headgear or protraction face mask is crazy easy to use, very low cost and very effective if you have a class 3 patient in a growing kid. Vertical corrections, really important. Remember, deep bites or overbites, same thing. Those will get worse over time. They will not get better. So it's really important to find that, to level the curve of speed. This is something that you can do in phase 1. You can also do it in phase 2, but it's not going to happen as well or as easily if the patient's done growing. So again, you have to know where the patient is skeletally and time it with the dental development too, which is, you know, why I love phase 1, phase 2. Really easy jumpers. I prefer this one over here that's got the little hex screw or the little screw. It's almost like an expander because, you know, it's very easy to measure. The patient or the parent can do it at home. Obviously, in this situation, this is an interesting appliance because this is probably not going to happen if you look at it. I mean, I didn't make this, but this wasn't my case. A lab sent it to me. But if there's no place to put the tooth, you can't advance it, right? So you'd have to, at the same time, be expanding the upper arch. So this would be a better appliance if you had a jack screw in it. This is a finger spring. I mean, some people use that. I have a hard time with them. They just really hard to activate. Ideally, you overactivate them, you underactivate them. This is probably only a few dollars more and it works way better. More expanders. All right, moving on to braces. We've got about 10, 15 minutes left, and then we will open it up for questions. I'll look for questions that really probably address the needs of most people, but if I don't answer your question, you're welcome to reach out to me. I will give my email again at the end. So braces are awesome. It's become significantly easier to do braces now with indirect bonding. There are a lot of companies that are out there that will offer you indirect bonding as a dentist. A lot of orthodontists use indirect bonding because it's great because you can set up the treatment plan ahead of time. So you can set it up, make sure the brackets are put on precise. Even though like I'm pretty good at putting on brackets, it happens, you know, like when they lecture, they might bump it or one kind of slides or you have to stand on your head in order to see tooth number 3, you know, and you don't quite get it exactly where you want to, or it got wet and you had to put it back on again, you get the idea. So indirect bonding is awesome because the computer basically places it like ideally. And then, you know, the doctor goes in and says yes, no, or modifies it. And it works just like a ClinCheck basically. You approve it. Once you approve it, the manufacturing facility will use your brackets. There's a lot of ones where you can use your own brackets if you have a preference. If you don't, there's quite a lot of labs out there that stock some really great clear or metal brackets, just kind of the standard mini twin, easy to use. If you don't know anything about putting on brackets, there's a lot of really easy digital courses that are out there that are really low cost that kind of teach you about IDB and how to do it. And you can do the manipulations on a Typodont. Very, very, very easy. You don't have to go to a course. You don't have to pay all kinds of money. It's very, very easy to get started, especially if you're picking really good cases. So IDB case as compared to cases that, I mean, at least with the general dentist who maybe doesn't quite put the brackets on right, you know, you need to make sure your IDB is computerized. So not all IDB labs or labs with IDB are using computerized setups. A computerized setup will be when they actually send you what the brackets look like ahead of time on the model. So kind of like this. So see here how they're sending you the brackets on the model and what it'll look like. If they're not sending you one of those, it's not computerized. And in that case, it's not accurate. So it's really important that you be taking that extra step to approve the bracket setup ahead of time and that it's ideally digitally placed. If you do that, you really shouldn't need to know how to bend wires because like I don't bend wires really. I know how to bend wires, but I don't have to because I put the brackets on right. If something just somehow randomly was off, I can always take it off and reposition it. That's just the way I do things now. I just find it way more efficient, even though I know how to bend wires. So I think if you have that in mind, it kind of takes one of those big push points away from doing braces because you know that they're going to be placed ideally to begin with. So, and it's just going to save you tons of time. Most cases you can probably do in 4 or 5 wires as long as you're strategically doing the steps in the right order. And that's something that you can definitely learn. There are a lot of great options out there to learn and feel free to reach out to me if you have questions. Main different types of brackets that are out there are going to be your metal, your ceramic, and your composite plastic. So if you're getting started, I'm not a fan of usually the composite plastic. I stick with metal and ceramic. Personally, I hate ceramic just because they're a big hassle. They're bigger, they're higher profile, patients don't like them, and they're a big pain to get off. But I mean, obviously back in the 2000s, before Invisalign got good, this was the only way to do things. But now, if a patient's really cosmetic, I say just get aligners. You can do everything with aligners now. So I mostly just do metal. If you want metal in colors, you get metal in colors. So two main different types of brackets that are out there, and you have to figure out what you're going to do. And I would just probably stick with one, to be honest. It makes your life way easier. It makes your overhead less. So either you're going to be using the mini twin, which is cheaper, or you're going to be using a self-ligating. So self-ligating is right here. So it has a little door that opens and shuts. You have to have something. Usually you can use a scaler. Sometimes you have to have a special instrument to open it. Cool thing about self-ligating is that you don't have to change the little rubber O-rings every appointment, because those do degrade over time and they lose their strength, right? So you save a little time. The thing is that the vast majority of kiddos that go through braces, the ones that are choosing braces instead of aligners, they like colors. So usually I think self-ligating is kind of working its way out. You'll occasionally have an adult that would prefer self-ligating brackets to Invisalign or to aligners just because, I don't know, who knows, they think they won't wear them. But I've seen the numbers go way down. So I think they're gonna and they're also very expensive. So I prefer just to keep stock a mini twin. But they are good because you don't have to see the patient as often. It really cinches it down really tight. So, and theoretically it supposedly goes quicker for that reason and has lower forces. So, but of course they're expensive. So that's one of the problems. And sometimes people want colors, and then, you spend all this money for extra brackets and no need. So again, I kind of talked about plastic brackets. I'm not a fan. I just find that it doesn't express the full prescription that well. They stain, they just don't look that good. They just don't perform to me to the level of a ceramic. And again, ceramic, we talked about, one of the problems with that is the friction. They're higher profile. They can wear the opposing enamel. They're a big pain to get off. It takes way longer to debond a case, and they're expensive. So, and I have some ceramics here. You can see, so obviously these placement dots go away, but they're definitely higher profile than the other ones. All right, so, and since we talked about Garrison a little bit before, and they've been so nice to sponsor this lecture, I just wanted to let you know that they do have a really good finishing burr. It's called the Rally. And I believe at the end of this lecture, you can get 20% off anything that Garrison sells. So I would recommend these. They do go on a slow speed latch, but they're really great at cleaning up after either attachments from aligners or after you debond braces. So cool stuff. So we're going to be talking about hybrid now, and this might be something that you've never ever heard of. So I'm just going to introduce it high level, but I know a lot of people that are doing this. So hybrid basically means taking a little bit of each type. So we talked about braces, we talked about aligners, we talked about sometimes the case is kind of hard and maybe you're not that comfortable doing it with all aligners, or maybe it won't be as efficient. Maybe it's a molar uprating case or something like that. So you can get the hard problems out of the way, with the braces, and then for 4 to 6 months, 4 to 8 months. And price point, just to let you know, indirect bonding is as low as $300 with the trays, the transfer trays, and the brackets. So you can get it crazy, crazy cheap now. Really high quality brackets. I'm glad to introduce you to a few labs that do it. But super cheap, right? $310, you pay that lab fee now, you slap the braces on, you get the hard limits out of the way, and then you can finish it up in some easy off-label, white label aligners, maybe $300, $400, $500 for the case. So full lab fee, way less than $1,000 for really difficult treatment plans, and that's certainly a lot less than $1,863. So that is pretty nice. And for a patient that's maybe kind of saying they want braces and they don't know if they want braces or aligners, it's a great way to get started, a little bit of both worlds. And you actually get all the benefits, because aligners are great for finishing movements, and finishing movements are a pain in braces. So, just a little step in between where you have to rescan. Lastly, we're almost done. We talked about the buckets. I didn't mention retention as a bucket, because at the time when I first started doing this lecture, it really wasn't a bucket, but now it's a bucket, because people are creating orthodontic aftercare programs. Whether you partner with one of the existing ones that are out there, there's a few that are out there, or you create your own in-house one, retention is an opportunity. And now that you can store your STL files, digitally, You know, you can offer your patients either an insurance program, which is on auto bill, low like monthly recurring or annual recurring fee, so that they can get unlimited retainers at said fixed price. So maybe it's almost, you know, I don't know. For example, I'm going to give you an example. I have 4 siblings. 2 of them, when they went to college, they lost their retainers. You know, that was, they may have had clear ones, they may have had metal ones, I don't know. But that was before things were stored in the cloud. So they had to fly home, get new impressions or scans. They had to have new ones made. Price point, even though it was the same orthodontist, they charged them $1,000 for one set of retainers for all that, new records, new this. Well, that's crazy expensive. So what you can do is you can create, you know, almost an insurance program or an aftercare program where maybe they're paying $5 a month, it's on auto bill, or they're paying $59 a year. There's a couple of turnkey programs that are out there where you'll store their, even if you didn't even do their ortho, you can still do it. Because I mean, people move around, right? I'd say probably if you polled, once you start just even having this conversation with your patients and finding out, you know, especially if they got pretty straight teeth, hey, you know, do you still wear a retainer? Come up, you'd be surprised, probably a lot do. Yeah, mine's kind of nasty, or no, I lost mine, I kind of need to get a new one. Clear retainers are only meant to last for about a year. So over a lifetime, you're gonna need, as if you're wearing them full time or every night, you're gonna need a lot of clear retainers. So great opportunity for you to just dive in with all your possible patients, you know, that have had ortho before, or maybe they are your ortho patients, which could be, like I said, hundreds and hundreds in your practice that might be interested in paying a very low annual fee and having access to low cost retainers at a push of a button. All they have to do is call, you know, maybe they get as many retainers as they want for $49 or whatever you want to do. And like I said, there are third-party programs out there that you can subscribe to. You get a commission and they handle this for you. So much cool stuff out there. Retainers, so many different types of retainers. Obviously, the clear ones are the ones you're probably most familiar with, but there's lots of different options. So you can create like I said, retention is an opportunity. So you can create a menu, different prices for different ones. What a great way for you to just earn a little extra revenue. And most of this can be done by your team members, but it can bring in a lot of passive revenue into your practice. And I think after COVID, a lot of us are really open to passive revenue because we really like, and that's, again, one thing I didn't mention is that cool thing about ortho, especially if you're having, you know, monthly payments or whatever, ortho can still go on, especially if you're doing, you know, removables, aligners, even braces, you know, it's still going on. You're still checking them. They don't have to come in monthly. They're still making their payments. It's on auto bill, hopefully. And you can check in virtually. So much can be done virtually to the point where now a lot of orthodontists are just, they're really going almost all aligners because they're like, forget this, you know, during COVID, I mean, my braces patients, they got behind, but my aligner patients, they progressed and I didn't even have to see them and the money still came in. And a lot of orthodontists were doing starts completely remotely. There was one, I went to a conference and she did 5 starts in a week, all virtually, you know? So much you can do. So just wanted to get you super excited. So much you can do. For more resources, we're almost ready for questions and Q&A, and I'm going to put up the code for your CE as well. But my website has tons and tons and tons of blogs, as well as the webinars are parked at gpwebinar.com. Our YouTube, we're not cool enough to have our own /one, but you can just search it up, StraightSmile Solutions. We have over 550 videos, pretty much everything you can think of. We have a how-to video that's all free for you. I'm also happy to talk to any Garrison people that were on the course today. Just email me if you have any questions. I'm glad to answer them. What intraoral scanner do you recommend considering factors such as cost, monthly cost, ease of use, and ability to do ortho and restorations? Great question. Thank you, doctor. So for that one, I think I would really dig into like, what are you going to be using it for? So obviously we've talked about ortho. If you primarily want to use Align Technology or Invisalign, then you pretty much don't have many options, right? So it's iTero or nothing. You're going to get monthly fees. It's a great, great, great scanner. Don't get me wrong. iTero is cool, especially if you want to do ortho because you've got the little like simulation set up and it's so easy to sell ortho, you know, but it's also really, really, really expensive. So not super portable. You know, I guess things to think about, like, what are you going to use it for? Is it more implants restorative? Is it more aligners? Are you going to start going white label aligners? Do you need to move it from room to room? I would also recommend, honestly, I mean, I know right now it's kind of hard to go to different like ADA and some of these other ones, but if you can go feel it, touch it, and make sure your team kind of is in on the decision, there's so many great ones out there. I'm just going to throw some ideas, but obviously I know Medit has some great deals are out there. I can refer you if you guys are on Business of Dentistry or some of these other forums. I know they have a super great deal. I think it's about $18,000 and includes the training, in-person training, the monitor. It has monthly payments. It's crazy, crazy cheap. So go on Business of Dentistry. You can learn more. Also, the Huron is really nice. It's super petite. It's about the same price, I think, but maybe not as big in terms of how many people have it. I don't know how good the training is, but you can almost like pick it up and just plug and play. So easy to do. So great questions. Let's see. Camera for photos. Well, I mean, it really depends. Some people are gonna go SLR because they're really into like photography. For me, I just want to take the picture. So one great thing is, like Invisalign does have their photo uploader app, which basically is idiot proof. You can take an iPad and you just hold it and it like frames it and it takes it perfectly and it orients it and it just dumps it into your thing. There's going to be, I'm sure, more companies that will start doing that. But I mean, honestly, I would probably just go with a simple iPad. That's what most people I know are doing. And that way, it's not something that could be used as a phone. You don't have to worry about the HIPAA, especially if you're not, you don't have a data plan or anything like that on it, as long as they're not allowed to use it for other types of internet stuff. So, yes, good questions. Why is there such a stigma against GPs doing ortho? Well, I mean, I'll take it from me. I feel like I'm kind of like old school and new school. So, I mean, when I chose ortho as a residency, there really was no Invisalign. Well, it hadn't launched, and we didn't even think it was, we thought it was a joke. So it was so easy, right? It was like turnkey. The referrals just came in, you just hang your shingle and here comes the referrals. Well, it's changed since then. So, and we worked really hard. It was a really hard specialty to get in. I think it still is, but even more so a generation or two ago. 4.0, we, had no social life. We had this goal, right? So all of a sudden now it's like, whoa, what happened to my profession? With everything that's happening, it's just changed, so you can either change with it or you can push against it. So I made a decision at the beginning of my career. I was like, you know what? My husband's a general dentist, so it really was an option not to help him and his friends. And I was like, you know what? They will still refer more to me, if I just support them with what they want to do and let them do the type of ortho they want to do. So that's the stigma, I guess. But, it's ultimately in what you do with it. So do you have a link to watch after today? I don't have audio. Oh, okay. We'll be sending it out afterwards.
Yeah, we'll send that out tomorrow.
Yeah. Another great question. If teeth are rotated, don't we have to unravel them first before IPR so that we're doing correct surfaces? Actually, doctor, you should watch our video from 2 weeks ago because we definitely addressed that. The cool thing, and I don't have all the IPR stuff because I was doing more of an ortho one, but you can pre-curve them so you don't have to unravel them first. That's a personal decision. Obviously, with Invisalign and ClearCorrect, you have a little more control about when to stage your IPR, and we definitely dig into that a lot in the previous webinar, so definitely watch it. But personal preference, I don't like to unravel them first because I'm what we call round tripping, which is where you're like moving them forward and then you create space to move them back. But sometimes in doing so, you can cause perio problems, bone problems, mobility, and it actually takes longer. So than if you just do it at the beginning. So, but great question. Great question. We're talking about spectrum. I actually have some really good YouTube videos just on this question about kids with spectrum, AKA autism, but kids on the spectrum. What are your recommendations? So, I mean, obviously it depends on how highly functioning they are, but for the most part, I find removables to be way, way easier, especially on a highly functioning spectrum patient. For the most part, super smart, great kids. You just need to explain the why. They don't hurt. They do tend to play with stuff, if it's removable, they click it around, but they love to be able to have that responsibility. They love often wearing something, sometimes just even aligners, no problem, really anything, but they're just really great patients, it's just a matter of seeing if you have the right team. But there's a lot of orthodontists that do work with a lot of special needs patients, so it might be something you want to refer out. What are the right questions to ask to help to project where the patient is with their skeletal growth? Fantastic question. So I don't know how easily Kevin and his team get embarrassed, but obviously we'll start with boys because boys are easier. Obviously for boys, my questions, I mean, it's kind of obvious with boys, right? Because their voice has dropped. You see an Adam's apple, you see facial hair. You don't really have to ask that. You could see stubble and stuff unless it's like 7 in the morning. But the question I usually start with, honestly, if I'm not sure, is, hey, can you tell me one of the questions, about your shoes? And when was the last time you had to get new tennis shoes, because they were too small, and a lot of times are your feet still growing? It's usually something definitely the parents know and the kids know, the boys know, and they're not embarrassed about that question. That's a pretty easy question, instead of some of the other stuff. So usually that directly correlates with mandibular growth and jaw growth as well. So you can go into that especially if you're not sure, but it should be pretty obvious with boys. Of course, with girls, you're asking the menstruation question. It's a little more sensitive. A lot of times if the dad comes, dad has no idea. A lot of times if you have it on the questionnaire, they're not going to be honest about it. I mean, my mom used to pass me my stuff to fill out and I was like, oh, I'm embarrassed. I'm not going to mark that. Why are they asking this? This is teeth, right? So you need to explain the why behind it to the parent and the patient. So we're going to be asking you this question. Obviously, it might be better to send a female team member in, only because we need to know if your bones are still growing or how much longer for growth that we have for your jaw, so we can time treatment ideally. So that's why we're asking. And like I said, it can be as early as 7 or 8. So you don't assume, and it's not necessarily based on height. And I think everything else, you're not going to be able to do it. And if somehow you really can't find out, you can always take that hand rest and it tells everything right there. You can, my email, Melissa, is on there. It'll be in probably the follow-up, so you can contact me and I can send that handout if you want to. Let's see. We got that one already. Recommendations for labs for IDB. Okay, I kind of said I wasn't gonna throw business to different labs, so you can reach out to me directly, but I mean, I can. So there's a few that I really, really like, and I'm just hesitant to say without saying some. I might get in trouble from some labs that are like, wait a minute, what about me? So Dr. Ho, why don't you reach out to me directly and I'll kind of give you the pros and cons and which ones I like and the pricing a little bit better. So let's see. TADs. There's a question about TADs.
Yeah, be careful with one of those questions coming up there.
Okay. I'm getting ready. I love fun questions. TADs, I think you mean TADs, not TDAs, but I do. I mean, that's not something I necessarily help doctors. I help doctors do a lot of ortho. So I mean, TADs are pretty advanced. So I mean, my daughter has a TAD, I can tell you that. So they're cool. I mean, but obviously you need to know how to put them in. You need to know how to take them out. I don't do that. That means I'm gonna have to refer to oral surgery or perio. That's gonna cost more money. It tends to be more traumatic. So personally, I think you should be referring to ortho for those cases. That's kind of where I leave it. So there are some questions about some other, no, I'll talk about this one. I'm fine with this one. What are your thoughts on fast braces? You can actually watch all my videos. I talk about that specifically. So instead of disparaging anything, I'll let you watch the video on YouTube. So, and I pretty much say what I think. But ultimately, the goal with braces and wires is to go slow and low with your forces. So if you're putting in a 20 by 20 wire initially, well, that's not slow and low, right? So also, you need to have some nice torque. And if you're only doing 20 by 20, you're not necessarily getting nice torque. So that is my opinion on that. Okay. Rotations and aligner treatment. Number 1, refinement. Most likely, doctor, the issue is that the treatment was too aggressive to begin with. I like to have for rotated teeth, especially canines and laterals, really big, old-fashioned rectangular attachments, the biggest possible. And you can ask for that, especially on Invisalign if you do, or anyone. I want big honking attachments. I want a handle to rotate my tooth. But of course, IPR is something that could be part of that as well. But yeah, you just need like a good handle. You need to make sure your treatment plan is super slow, especially on rotations. Just because the computer says you can do it doesn't mean it's possible. Always okay, especially if you're doing Invisalign or ClearCorrect Unlimited, to ask for the treatment to be twice as slow. So if they say they're staging it in 22 aligners, it looks like a good treatment plan. One of my hacks is to say, turn this into a 45. Now, they're not going to love you for that because it's going to end up taking away from their profit. but it works beautifully to try to get things to track. You're not paying any more for that. Patient's not going to even know. And if somehow that patient is crazy tracking, like slam dunk, if they're telling you, hey doc, after day 3, this stuff is getting crazy loose, they're checking in, they're tracking, you can always speed up. So you can have them go every 4 days or every 5 days. That's a one-off. So like I said, you always better to, I always say this wrong, under promise and over deliver. So, but that's one of my hacks for ClearCorrect and Invisalign Unlimited, is just to do that. And that usually will solve your rotation problem. How do aligners accommodate for growth and eruption of teeth in phase 1? Good question. So if you're using Invisalign first, they have some patented features to accommodate for that. But ideally, if you're using white label or ClearCorrect, I would recommend staging your phase 1 aligner treatment ideally. So that means you need to kind of, there's a 1-year latency period, I would usually say approximately. And if you have kids, you've experienced it where 2 to 2 has come in, right? The front 4 teeth, the bottom 4 teeth have already come in, and now like they're probably not going to lose any teeth for about a year or a year and a half. You want to time your phase 1 for that. Now, sometimes I'll take out, baby canines or something just to give me a little extra time. With both ClearCorrect, Invisalign, and the white labels, they can put Pontics in too. For missing teeth, you can, fill them in with Pontic material. Really cool stuff. So there's a lot of things you can do. But yeah, timing is the key for, unless you're going to do Invisalign first, which has unlimited revisions, refinements within 18 months. So, but it's kind of a hassle, right? Because you have to keep rescanning them. Okay. Okay, scanners for implants restorative. Again, I'm an orthodontist, so I don't really do those, but most of my general dentists tell me they like Medit or 3Shape. Medit's way cheaper. It's like a third of the price. So, love that question.
I told you.
That's my answer. Sorry. And I have 2 kids too. You saw them in the picture.
Yeah.
Okay, thank you so much. You guys are so sweet. Okay, oh, the paperclip story. Yes, that's awesome. Question, is it not far more likely to go through the buccal plate with fixed than with removable, or is that all old style? No, I've seen teeth go through the buccal plate with removable too. So I mean, yeah, if you have fixed there, it can go quicker, I would say. But yeah, I've seen it happen multiple times. I've also seen it happen with expanders if it's done on too old of a patient. Question about attachments. Do you prefer packable or flowable composite for attachment? Great question. So I do it both ways. For flowable, my recommendation, is to get the aligner and there's no attachments on this one. Okay, let's find another one. And to get the aligner and, I don't even have the picture on. Hi, okay, I'm back. I'm just like holding things up and I realized I don't even have the video on. Okay, so you can see here the attachment, right? If you're gonna use flowable, I would take an Explorer and go from in to out like this. So that way the little pokey flash is on the outside, on the edge of the attachment, and that way the flash will go through the hole. And then when you take it off, it just cracks and you just polish it. So that's what I would do. Otherwise, using flowable is a hot mess, so I would not recommend that. So the answer normally would be packable, but that does work, the little hack, if you only have flowable. So, but there's an art to doing that for sure. So I think that might be our last question. Yay! All right, everyone, have an awesome night. I know it's super late for you East Coast people. Here in Hawaii, it's only 3:30, so we're gonna go to the pool or the beach or something. So
That sounds like a wonderful idea. Wonderful idea.
Awesome. Well, aloha,
Dr.
everyone.
Amanda,
Thanks,
thank you so much for another wonderful webinar.